My name is Michell Chresfield, and I'm a lecturer here at the University of Birmingham, where I lecture on the history of race and medicine. And today, I want to talk to you about new medical histories. Not the kind I typically do, that tends to focus on messed up things that happened in the past. No, today, I want to talk to you about some of the messed up things that are happening in our present. Specifically, in today's talk, I want to make the case for why asking about a person's past experiences of medical racism is just as important as asking about their past experiences of heart disease or diabetes. What COVID and the racial reckoning of summer 2020 have taught us is that racism extends beyond police brutality. It encompasses the myriad ways in which Black lives are devalued and dehumanized. Healthcare and medicine represents an important but too often overlooked aspect of this dehumanization. We know that people carry their experiences of medical racism with them long after the encounters are over. Cumulatively, these experiences impact not only minority health outcomes, but the ways in which minority peoples engage the healthcare system writ large. Like many of you, I've spent the last year really trying to come to grips with the world around us. And for me, COVID has not so much necessitated a pause, so much as a slowing down. And in this slowing down, I've really been granted the space to reflect on the world around me. And for the most part, I've been really shocked at the degree to which our histories of medical racism continue to haunt our present. In the early days of COVID, I was struck by this idea that Black people were somehow immune or less impacted by COVID. It was most popular, this idea, in the United States, though African and Caribbean countries with their warmer climates and low early COVID figures were often marshaled as evidence. According to Greg Townsend, a former healthcare administrator for Jefferson County, Alabama, it was the melanin in Black skin that was somehow responsible for Black people facing lower numbers of COVID. And there was even the suggestion that this was somehow divine intervention. And so you have a quote like this one, which says, COVID lowering gas prices, flights, cruises, and not messing with Black people, God showing out. And then there was even the suggestion that COVID was due to the radiation brought by 5G technology. And so here's a photo that I took on a walk out in the jewelry quarter. And for the record, I include this example not because it has anything to do with race, but I want to make clear that conspiracy theories cut across racial divides. When the British actor Idris Elba contracted the virus in March 2020, he made it his mission to ensure that Black people understood that they were at risk. And I won't read his full quote, but I will read what I think are some really important bits. And he says, "My people, Black people, please understand that coronavirus, you can get it, all right? Wherever we are, please understand that you can get it. Just know you have to be as vigilant as every other race. This disease does not discriminate. As a Black person who has contracted the virus, it needs to be said." What struck me was the ways in which this idea of Black difference fit this long history of ideas claiming that Black people were biologically different from whites. What's interesting here, however, is that this idea was mostly perpetuated by other Black people. Historically, this has been an idea of white supremacy used to justify slavery, colonization, and the general marginalization and dehumanization of Black and minority peoples. For example, during the yellow fever epidemics of the 18th century, physicians routinely advanced the idea that Black people were immune. For example, in 1748, John Lyman produced a study on the yellow fever pandemic in Charleston, South Carolina, and he wrote, quote, "There is something very singular in the constitution of the Negroes, which renders them not liable to this fever," end quote. What we know now is that any immunity, if present at all, was not due to innate biological difference, but to the fact that yellow fever had been endemic to parts of Africa. Therefore, Black people in the Americas were most likely previously exposed, gaining what we today call acquired immunity. However, in 1793, when yellow fever struck the city of Philadelphia, the prominent physician Benjamin Rush called upon Black Americans to serve as frontline workers in combating the disease. However, this time Black Americans did not show that same immunity and suffered right along with other white Philadelphians. And it is important to note that this racial essentialism is not limited to the US. The outbreak of Asiatic cholera in 1817, so named because it originated in India, worried Europeans who were concerned that the colonized were spreading the disease. The epidemic caused particular scrutiny of lepers, who were eventually institutionalized. The sociologist Alexander White has called this epidemic Orientalism because this thinking helped to frame the colonized world and colonized peoples as the space from which white Europeans needed to be protected. Yet far from being immune, early figures on COVID in both the US and the UK signaled that Black and South Asian populations were being disproportionately impacted. By April 2020, 33% of hospitalizations for COVID in the United States were amongst African Americans. This despite the fact that African Americans only made up 13% of the population. In the UK, the first 11 doctors to die from COVID were from Black and minority ethnic background. Take, for example, also this. An analysis by the Institute of Fiscal Studies, published on May 1st, 2020, revealed that the mortality rate from COVID amongst people of Black African descent in English hospitals was 3.7 times higher when compared to rates amongst white British people. And according to a Public Health England report published in June 2020, the risk of death among people of Bangladeshi ethnicity was twice that among people of white British ethnicity, while people of Chinese, Indian, Pakistani, Asian, Caribbean, and other Black ethnicity had a 10 to 50% higher risk of death than white British people. But even as Black and South Asian people were disproportionately impacted by COVID, we continue to see ideas that somehow their innate biology or even genetics were involved. One particular theory that has proven popular pointed to correlations between better immune responses to COVID and vitamin D, which is harder for darker skinned people to absorb, particularly when they reside in colder climates. So by May, we see articles like this one from Dr. Winston Morgan, who is writing to dispel the myth that Blackness is causing the disproportionate number of COVID cases amongst Black Britons. So first we see Blackness marshaled as reasons for why Black people aren't getting COVID. Then it's marshaled as reasons for why Black people are getting COVID. So it works both ways. And May would be a big month for the discussion of Black mortality for another reason. On May 25th, George Floyd died at the hands of white police officer Derek Chauvin. And the video of that encounter, lasting 8 minutes and 46 seconds, showed Chauvin leaning on Floyd's neck while he pleaded, "I can't breathe." That senseless tragedy occurred on the heels of other deaths, senseless deaths of unarmed Black people, including Ahmaud Arbery, who was killed on February 23rd, Manuel Ellis on March 3rd, and Breonna Taylor, who was killed on March 13th. Floyd's death set off a tide of protests around the globe, from the US to Paris to right here in the UK, spawning what social commentators have called a racial reckoning, as people around the world begin to think through the ways in which Black bodies have been dehumanized, exploited, and denied the right to exist. Most importantly, these demonstrations mark widespread affirmations that Black lives do indeed matter. Many have wondered, and I think it is a valid concern or question, whether these protests would have happened if the world had not been forced to pause or slow down. And the truth is, we'll never know. But what we do know is that these protests have spawned new calls for racial justice and racial redress, and they've spawned new debates about the systemic conditions that impact Black life. This reckoning has also shedded much needed light on the fact that Black and other minority people suffer not just at the hands of police, but through systemic structures that prevent them from accessing equal opportunity in economic, educational, and healthcare settings. In many ways, the uprisings of BLM and COVID have exposed racial injustices that existed long before COVID in both the US and the UK, and have given them added immediacy. Take, for instance, way before COVID, In both the US and the UK, Black maternal mortality rates were frighteningly high and disproportionate to the white population. In the UK, Black women are 4 times more likely to die in pregnancy or childbirth than white women. Women from Asian backgrounds are twice as likely to die. In the US, Black women are 2 to 6 times more likely to die in childbirth or pregnancy. These numbers are, for lack of a better word, monstrous. Researchers in both countries attribute this, however, to racial bias in medical care, particularly not taking patients seriously when they complain of pain. And this is a particular phenomenon amongst populations of color. So far from innate differences, we know that structural racism, pre-existing conditions, lack of healthcare access, and poverty all couple to shape the health outcomes of minority peoples, both during the pandemic and prior. We know that our frontline jobs, care home workers, nurses, transportation providers tend to be staffed by members of the Black and South Asian population. These same jobs also tend to be underpaid. And couple that with uneven access to health care, the existence of comorbidities like heart disease and high blood pressure, things which are shown to increase the morbidity of COVID-19, then it becomes clear that structural issues, most notably income, have a disproportionate impact on healthcare. But these facts should not absolve us, and I want to say it again, these facts should not absolve us from considering the ways in which racism impacts access to healthcare and medical outcomes. In a recent survey, up to 29% of BAME staff in the NHS reported being harassed or bullied by colleagues in the past 12 months. And respondents also reported facing similar indignities from patients. Add to that a study by the King's Fund, which reported that within the NHS, Black doctors earn $10,000 less and Black nurses $2,700 less annually than their white colleagues. As this evidence suggests, structural racism can affect all aspects of our society. You cannot earn or achieve your way out of this problem. While the events of summer 2020 have allowed some of us to have a more robust understanding of racism, the type of racism which underlines health inequity remains harder for some of us to grasp, particularly in the British context, where racism is more commonly understood as open name calling or blatant discrimination. With the vaccine now introduced, we are seeing reports of minority communities who are skeptical. Some cite the short period of development, though journalists, social commentators, and researchers have also pointed to the long history of medical racism amongst Black and minority peoples. And the most often cited example is the Tuskegee experiment, which was a 40-year study of untreated syphilis in Black males in Tuskegee, Alabama. Even after penicillin was introduced as a viable cure, researchers withheld that treatment from study participants, and often we find that those participants did not understand what was wrong with them in the first place. And although there are numerous examples of medical racism, Tuskegee often stands out as that paradigmatic example of why people are mistrusting. So then you get sentiments like this one, which says, I need politicians to stop saying the Black community doesn't trust our vaccine and start saying we have a history of medically abusing Black people, and thus we violated their trust. Yet focus on Tuskegee does not address all the ways in which Black people and minority peoples experience racism in medical settings, from being stereotyped, racially profiled, and not having their complaints taken seriously. Add to that the degree to which minority peoples are forced to serve as their own advocates, then you see a system that is structurally opposed to the good health outcomes of minority persons. So there's a history of systemic racism in medicine that influences how minority communities think about and engage with their healthcare. So clearly, our past is impacting our present, and it threatens to impact our future if we do not change the ways in which we allow minority peoples to engage their healthcare. And so for this reason, I'd like to propose new medical histories. We know the importance of taking medical histories from diagnostics. For example, one study showed that by taking history alone, it led to a final diagnosis in 76% of patients. Yet patients are not provided the opportunity to disclose information about their histories and their engagement in medicine. Too often, physicians enter the patient setting as if they're meeting the patient at a place of zero, as if the medical examination is happening not in the context of centuries of medical racism and exploitation. And we might consider that this unwillingness to lend patients the space to speak their truths as part of that structural racism which silences and marginalizes. And some of you may point to the recent study by the Commission on Race and Ethnic Disparities report released on 31 March. The commission, founded in the wake of the BLM protests last year, noted the progress in eliminating the ethnic pay gap and closing the educational attainment gap. And according to the commission, success in education, and to a lesser extent the economy, quote, should be regarded as a model for other white majority nations, end quote. While many will celebrate this report as an official disapproval of structural racism's presence, let me draw your attention to another report. The McPherson Report, published in 1999, also known as the Stephen J. Lawrence Inquiry, is notable because it provided a definition of institutional racism, which is a form of structural racism. And it describes it as, quote, the collective failure of an organization to provide an appropriate and professional service to people because of their color, culture, or ethnic origin. It could be seen or detected in processes, attitudes, and behavior that amount to discrimination, though prejudice, ignorance, thoughtlessness, and racist stereotyping which disadvantage minority ethnic people. And it is this thoughtlessness that is harder to combat and all the more important for us to confront. We must seek out and listen to minority peoples in our society. We must trust them when they tell us their experiences and how it impacts their present. Only then will we be able to ensure they have better health outcomes. Only then will we be able to ensure that Black lives matter.